I wanted to put together a quick and practical guide to osteoporosis for the general medical practitioner. DEXA scans should start at age 65 in all women. You can start earlier in postmenopausal women with risk factors. There's no recommendation for men, and they should be repeated every 2 to 5 years. There's some debate over that number, and some people say you can go out farther. Regarding DEXA results, the main number you need to know is negative 2.5. Less than this is osteoporosis and requires pharmacotherapy. So a T-score of negative 2.5 means pharmacotherapy. Anything better than that is just lifestyle mods, and frankly you should be telling every female postmenopausal age to take calcium, vitamin D, quit smoking, and exercise anyway. Those are the lifestyle mods. That's a potential further workup. The majority of this presentation is going to be on pharmacotherapy. The mainstay in pharmacotherapy is bisphosphonates, and the best bisphosphonate is alendronate. This class of medication is the superior drug for osteoporosis management. They do have some side effects, and that has something to do with abnormal bone remodeling with prolonged use. This can cause jaw necrosis and atypical femur fractures. For this reason, patients are kept on a bisphosphonate for about 5 years and then given a holiday. During the holiday, you continue to monitor DEXA scans and restart the bisphosphonate if T-scores begin to worsen. Bisphosphonates are also a little hard on the GI tract and are not necessarily the best choice for people with esophagitis. People with esophagitis can get IV bisphosphonates, and the best IV version is zoledronic acid. All the same rules apply. One of the benefits of zoledronic acid is that it's a once-a-year infusion. If patients have severe osteoporosis, meaning a T-score of less than 3.0, multiple fragility fractures, or osteoporotic T-score with a fragility fracture, you should consider an anabolic agent. The best anabolic agent is teriparatide, and that's a recombinant parathyroid hormone. It does increase the risk for osteosarcoma, so it's not used indefinitely. It's only used for 2 years to rebuild some bone, and then you switch to a bisphosphonate. Some second-line medications, one is denosumab. This is used indefinitely. It's an osteoclast inhibitor. It may cause hypocalcemia, so that's just a reminder to put everyone on calcium and vitamin D. Another second-line medication is raloxifene. This is a selective estrogen receptor modulator. Because it works with the female hormonal system, it can increase the risk for thromboembolic events and causes hot flashes. One benefit is that it reduces the risk for breast cancer. It is also used indefinitely. A third-line medication is calcitonin. I like this one because it works as an analgesic, particularly in people who have had osteoporotic fractures, but I've even used it in people with vertebral fractures with some benefit. It is less effective than other medications and carries a little increase in cancer risk for various types of cancers, so it is not used long-term. It's essentially used until pain improves, and then medications are switched, usually to a bisphosphonate. Regarding monitoring on therapy, you should repeat your DEXA scan 2 years after you start pharmacotherapy, and then depending on results, continue repeating every 2 to 3 years. That's about the same interval I mentioned earlier for regular screening. If your patient has a worsened T-score on pharmacotherapy, check and make sure they're taking their medication and adhering to lifestyle modifications, and if they are, consider a change in therapy. That's it, quick and easy.